Your station for up-to-the-minute news and intelligent, interactive, and engaging conversations. 96.9 FM. The views and opinions of the hosts and guests are their own and do not necessarily reflect the views of the management and staff of Guardian Radio.
With early detection comes early prevention. Put lead in your pen so you feel like a champion. Rise up again, let nothing keep you down. To live your best. Hear the urologist speak. Oh yeah, oh yeah.
Think you're losing grip of your manhood, don't give up on hope.
Don't be ashamed, it's time to take control. Get some help from the urologist.
You will find
He'll help you solve your problems
on 96.9, yeah.
I telling you, with early detection
Comes early prevention.
put lead in your pencil, make you feel.
Good evening, Bahamas, and everyone listening. My name is Dr. Graham Cates, and welcome to Urologist Speaks. I'm going to be hosting you tonight. Dr. Pinto is away, and he has given me the honor of looking after you this evening. So welcome, and thank you for joining us. This evening in the house, we have a cardiologist and cardiac electrophysiologist, Dr. Morris, who is a friend and a colleague who works along with us at Family Medicine Center. By way of information, I am the medical director of Family Medicine Center, and we have our practice located on Blake Road, and we also have a facility on the beautiful island of Eleuthera. If you've never been, I highly recommend you take a chance to go and visit. It is a beautiful place to enjoy. So, Dr. Morris, welcome.
Thank you so much for having me, Dr. Cates.
Absolute pleasure. So tonight we're going to talk a little bit about heart health. And we'll start off with some simple things, and we'll talk about some of the common ways that we can protect our heart and protect our blood vessels inside of our body, and also talk about some of the common things that we see from a general practice point of view and a specialist point of view in outpatient care. So when we talk about the heart, what are some of the basic sort of 101 things, Doc, that we really want to know about the heart?
So, how I usually break it down for my patients is this. I say the heart is like a house. The house has walls, it's a structure. And then those walls beat to get blood from the heart to other parts of the body. And with that, in order for it to function properly, there are pipes. These are what carry blood to the heart itself. And then there's electricity as well. And that allows the heart to beat at a particular rate and rhythm, depending on what you're doing. And generally, your heart is what kind of is central to you having overall health. Because for me, the heart is not just the heart, but it's also a structure which leads to a vascular structure. And all these blood vessels go to every single organ in the body.
I love the analogy that you've drawn there. I've never heard that analogy before, so thanks for sharing that. That is a great analogy. The heart is like a house, and it's so true. You know, all of the components in the house have to work properly to make it efficient, right? And so all of those pieces have to be functioning in the way that we need them to actually be able to function. So when we look at the heart in terms of just the general physiology of the heart, what is normal in terms of heartbeat, heart rate? What are some of the common things that we want to empower people with this evening that they should know, and even as it relates to a normal blood pressure?
Yeah. So for the heart, a normal heart rate is somewhere between 60 to 100 beats per minute. And of course, your heart rate is dependent on what activity you're doing. I would say sometimes your baseline heart rate tends to generally give you what your cardiovascular health overall might be. So generally for somebody who's athletic, your heart rate is pretty low. So sometimes even less than 50 beats per minute. So sometimes can be 40. So if you're athletic, that is maybe a normal physiologic heart rate for you. And then if you're doing activities, your heart rate should go up to about 100 beats per minute. And of course, we kind of use what we call your target heart rate based on your age to determine how high your heart rate can be with aerobic exercise. So
And
it's
so
like,
when you say aerobic exercise, what would be an example of that?
so like, brisk run, a brisk walk, sorry, or a run.
Okay.
That is mostly aerobic or exercise, or even a run.
So
pretty
not
much.
sitting down on your
Not sitting
iPhone
down.
and sitting down in front of your computer.
No. Getting your
I
heart
hope
rate
we all
up.
got that, folks. This is an important infomercial here. Yes,
Yes.
activity.
Activity.
Yes.
Very important for heart health.
So getting your heart rate up. Now, in terms of target heart rate you mentioned about, what is the general formula that is used for people that may be interested in sort of looking at their sort of target heart rate, and why is it important?
So for me, I see target heart rate as a way to see if you can actually get your cardiovascular health up so that you are doing aerobic exercise to maintain health. And, when we do recommendations based on your WHO, it's, you need to get your heart rate up for 30 minutes, at least 5 times a week.
That's about
for
150 minutes.
150
That's what we're
minutes
trying
for
to
a
target.
week. Yep, 150 minutes a week. Sometimes people could even go up to 50 minutes 3 times a week, but all within that target, and getting your heart rate up in terms of aerobic exercise. And the formula that's used is 220 minus your age. That's generally what it is. And we say
So
that's
pull out your
yeah.
phone, 220 minus your age, and calculate your heart rate while we're talking about it.
Yes, and that's how you should get your heart rate up when you're exercising.
Amazing. So that's a
Yes.
good thing to do, and making sure that it's some cardiovascular activity that you're doing
Exactly.
just to help. A brisk walk, a light jog, a swim if you enjoy swimming. I love
Yes.
getting out on the boat and swimming, so that's one of the things I love doing. So finding something that you enjoy doing.
Yes.
I think that's a really important part
Yes.
to making sure that you make activity fun.
Yep.
Often I hear people when they come to see me at the office, my area is family medicine that I'm involved in, and people will come in and say, well, what is the best exercise that I should do? And you know what my response is? Whatever
that you
you're going to
enjoy.
do, whatever you enjoy doing.
Exactly.
Get out there and do something.
Because there are days you will not want to do it. But if you enjoy it, you probably will get up and do it.
Exactly. If you have a family, get outside with the kids, play the ball.
Your dog.
The dog. If you have an animal, get out and spend some time walking around the community. Of course, we want you to be safe, and so make
Yes.
sure that you're safe in doing the activities that you're doing. So we talked about heart rate. I want to talk a little bit about blood pressure. So blood pressure is really a function of the heart and also the blood vessels. And so when we look at blood pressure, what is a normal blood pressure for the average adult, and when does it become abnormal?
Yep. So for the average adult, I would say the normal heart rate is anywhere between 120 to 130.
Blood pressure.
Sorry, blood pressure. My apologies. Blood pressure 120 to 130 millimeters of mercury. That's your systolic. And then the diastolic should be between 80 to 90 millimeters of mercury. 90 is actually considered to be a little bit on the higher end. But for some people, we actually allow them to have what we call permissive hypertension. So allowing them to have a little bit of a higher blood pressure depending on their condition. But generally, the average is 120 on 80 millimeters of mercury.
So 120 on 80. And how often should people be having their blood pressure checked as an adult? And when should we start checking blood pressures?
So the Caribbean is an interesting population.
Hello, very much so.
Or I should say,
wonderful people.
or I should say Afro-Caribbean.
Yes.
I think we should start getting our blood pressure checked somewhere around the age of 30 or even younger,
Wow.
if possible. Just because I've seen some very interesting cases where patients actually start to have end organ damage at the age of 30.
Wow.
I have one patient who's 29 years old in my practice who has left ventricular hypertrophy, which essentially is high blood pressure affecting the heart muscle. And the question is when that process starts. There's no hard and fast to saying it started a year ago, 2 years ago, but it certainly is something that did not start yesterday.
Yeah.
That's
So
a
regular
long-standing.
checking of your
So
blood pressure.
regular checks. We're talking about twice a year for most healthy adults. If you're known to be hypertensive or you have high blood pressure, I would say checking it at least twice a week for you, just to make sure that you're within range, and that helps to gauge and helps you to be part of managing your blood pressures. Because you come into the office sometimes, and sometimes we as physicians don't have a good marker as to what their normal range is for a patient. And doing home blood pressure readings where you're in a relaxed environment, where you're calm, where you can have time to sit and do your blood pressure. Most patients come run up these stairs in the office. They're anxious. They're a bit late. They were in traffic.
Right, yes.
Their catecholamines are high. Anxiety is high, and their blood pressures are like 160s, on 90s, and you're like, okay, well, this is not normal.
Right.
You wait for a few minutes in the office, but then you have patients waiting. So sometimes the blood pressure or the office readings are not quite accurate.
Yeah. And so when we look at the normal blood pressure, anything above 140 over 90 is considered elevated.
Yes.
And so those are patients that we want to identify, and
Yes.
we want to make sure that we are properly managing that. Now, when we talk about hypertension, which is a very common chronic non-communicable condition that we see, which is the elevation of pressure inside of the body in the blood vessels.
Yes.
When we identify somebody, there are certain risk factors
Yes.
associated with the development of hypertension. One of them we mentioned is just genetics,
Yes.
which are genetic predisposition.
Yes.
Afro-Caribbean, Afro-American people have a greater predisposition.
Yes.
What are some of the other risk factors that patients have with the development of hypertension?
Yeah. So we talked about exercise earlier. So somebody who has a sedentary lifestyle, so just again, kind of couch
Sitting down all the
potato,
time, yes.
not getting that 30 minutes of exercise. Smoking, as we know, is a risk factor.
And that's something I'm seeing more and more of
Yes.
nowadays. Unfortunately, a lot of the younger people are smoking. I'm also seeing a number of
Vaping.
people vaping, which is really becoming not a good trend.
Yep.
We know that there are so many adverse long-term effects associated
Yes.
with this. Even with a short period of time that vaping has been around,
Yes.
we can see the damage that's happening on the cardiovascular system.
But also
and
respiratory as well, so
respiratory
lungs
as
as well. Yeah.
Exactly, with
Yeah.
lung disease that we're seeing. So for those of you who are listening, if you are vaping, if you are smoking, this is a moment to say it is not good in any way, and please get some help. If you need help to be able to stop, see your primary care physician, see your physician. There are tools that we have available to be able to assist
Absolutely.
you, to help you with discontinuing smoking cessation programs. So you mentioned about the lifestyle. We're talking about genetics. We're talking about obesity, which
Yes.
we're seeing a lot of
Yep.
generally as well. And so these are all predisposing factors to hypertension. One of the interesting things that you mentioned earlier, and I see this often, is that patients will come into the office, they'll have an elevated blood pressure, they'll also do blood pressure readings at home, and we can see that their blood pressure may be consistently elevated, but there's also a mentality of people saying that I'm not claiming this. I'm not willing to
Yes.
accept this.
Yes.
It's the reality of what they're faced with. How do you deal with that with your patients? Like, how do you navigate that?
I think honestly, it requires a lot of patience.
Patience for patients.
Yes.
Yes.
A lot of patience. Because I think if you kind of throw it down to them, this is what you have, you accept it or you don't accept it, a lot of people still don't change anything as it relates to that. For me, I give patients kind of time and sometimes even reading materials so that they have a good idea in terms of education wise, and I kind of put it on them, but also try to do it in the office as much as I possibly can. But I take time to do it. So reading materials about, hypertension, what it is, and what potentially can be the risk associated with having long-standing hypertension, which is not managed or not controlled. So that is something that I tend to do a lot. There's also, so people may say, well, doc, I come into the office, I do it, I purchased my own blood pressure machine and
Right.
I'm doing it. And some people may even say, well, doc, these are the numbers that I'm getting at home, are selective in terms of what they choose to show you.
Yes.
So for some of them, I actually adopt, and this is for a lot of people who have hypertension, I kind of adopt the ambulatory blood pressure monitoring for them. So I say, hey, so we just on the same page. Let's try to do this where you're going to take home a blood pressure monitor for 24 hours, and we're going to see what your blood pressures are like. And for me as a cardiologist, the worrisome thing thing that bothers me a lot is when your blood pressures are elevated at night, because that is associated with adverse cardiovascular health.
Sure.
Because your blood pressure is supposed to drop in the
Right.
nighttime.
Yeah,
Because
you're
you're
laying
sleeping,
down,
you're
you're
not doing
sleeping.
anything,
Yes, exactly.
right? And then it's also a marker to find out other things. For example, sleep apnea, which people may not even recognize that they have. And treating that could actually also treat their hypertension as well, or their elevated blood pressures. So I think that's the type of method I adopt. And then, of course, I say, okay, so you might not claim this, but let's also look at how can we address a healthier lifestyle overall. So we talk about, if they're smoking, the potential ways we can go through smoking cessation. If they are obese, ways we can start talking about exercising and weight loss, and whether weight loss be just targeted towards a healthier diet and exercise, or also using things to help. So
Sure.
medications to assist.
So one of the things that we commonly talk about in medicine is hypertension as a silent killer.
It is.
So why is hypertension a silent killer? And that term is used globally in all nations to
Yes.
discuss and talk about hypertension with patients.
So when we say hypertension is a silent killer, the first thing is that you may not have any symptoms associated with hypertension. Your
What's
blood
the
pressure.
highest blood pressure that you've ever seen out of in clinical practice?
So I was at the hospital.
Like?
I will never forget this. So I was at the hospital in Barbados on call as a young SHO, and the emerge doctor came and said they have a blood pressure of 280. This patient had a blood pressure of 280 on maybe 160, for example.
Wow, well, keeping in mind, normal blood pressure is 120/80, right?
So I go downstairs. The patient also had heart failure at the time. And of course, we were going to admit to the ICU. Went downstairs to put in the arterial line. And as soon as I got the arterial line in, I saw 300 and something. And I started to freak out. I was like, this is crazy. And this person is, they're short of breath. But would they have expected that they had a systolic blood pressure of 300?
Wow, incredible.
Still living.
Yeah, amazing.
But
So back to the
yes,
question of
yes,
hypertension
yes,
being a silent killer.
yes.
Yeah.
So when we talk about it being a silent killer, it's not just you not having any symptoms,
Right.
but also the fact that it can affect every single organ in the body, every single organ. So we're talking from head, we're talking about the risk of strokes, whether that be a bleeding type or an ischemic type, meaning there is a blockage in a blood vessel. Risk of eye damage. So we're talking about bleeding to the back of the eyes, for example. Heart issues where you get thickening of the heart muscle, and then eventually you can get heart failure. And that type of heart failure is the most difficult one to treat. And we do not have a lot of drugs that we have effectively studied like, the other type of heart failure. There's also kidney damage. People don't even know that, this is an issue, but a lot of people turn up in kidney failure
Right.
requiring dialysis. And that could be the side effects of having longstanding high blood pressure. We're also talking about vascular disease as well, can also affect you. We're talking about that vascular disease, either particularly being to the heart, where we're affecting the coronary arteries of the heart to increase your risk for having a heart attack, or just generally causing blockages to the peripheral blood vessels as well.
Yeah. So, I mean, as you know, it spares no part of your body, literally from the top of your head to the bottom of your toes is affected by hypertension. And if you're diagnosed with hypertension, you want to be mindful of the things that you need to do. The lifestyle is important. And then there are also medical management associated with hypertension that can be used and safely used to be able to help to prevent long-term complications associated with hypertension.
Yep.
I think one of the myths that is often pushed out into the community is these medications cause kidney
Harm.
disease, they
Yeah.
cause heart disease, a stroke, or they cause the complications that patients see. But we know from all of the medical evidence that really is not the case.
Yeah.
Because the vast majority of people tolerate medications, they tolerate it well.
Yes.
Now, some people do have side effects
Yes.
associated with medications, and that's where it's important to have a relationship with your healthcare provider.
Yes.
That if you're having side effects from a medication, you can
Let
then
us know
come to your
first.
healthcare.
Yeah.
Absolutely come. We want to know so that we can help to best manage your health. And if you are having side effects, speak to your healthcare provider so that they can then say, okay, well, hey, there are alternatives there.
Yes.
And not one size fits all.
Yes.
Right?
That is very true.
You have to
And I
look at
tell
your
my
patient and you have to look at their genetics, what is their
Yes.
family history, their race. These are all important variables that are looked at when we choose medications for patients.
Absolutely. Yep.
Yeah. So we talked about hypertension, a very, very common condition that affects persons in the Caribbean, and everyone can be impacted by it. One of the other things that I wanted us to talk about is as we look at the heart and the structure of the heart, the arteries of the heart. So coronary artery disease. Let's first of all just talk a little bit about the normal arteries of the heart, how they actually work, because I don't think a lot of people appreciate that the heart is a muscle. And just like every muscle inside of your body, it needs oxygen and nutrients.
Yes. So that's what the coronary arteries do. So the beauty of the heart is that it supplies blood to itself as well as blood to the rest of the body.
Yeah.
So you have 3 major blood vessels, sometimes 4, and these all carry blood through what I call them the pipes of the heart. And these pipes carry blood to the heart muscles, so it gets oxygen, it gets nutrients, as you said before. Now, when we talk about these blood vessels or coronary disease, which it's termed, affecting these blood vessels, we're talking mostly about not just sometimes people can have genetic abnormalities, which they were born with,
Right.
where the blood vessels take an abnormal course. We're not talking about that. We're more specifically talking about the formation of plaques in those blood vessels, something we call atherosclerosis. So that the risk factors, as we know for that, is similar to the development of hypertension or even diabetes, again, which is a sedentary lifestyle. You have your other risk of hypertension or high blood pressure. Diabetes is a risk factor. High cholesterol is a big one there. Smoking, again, sedentary lifestyle. Genetics as well. Genetics plays a big role, to be honest with you, especially when talking about genetics related to high cholesterol too.
Yeah. So when persons are developing heart disease, what are some of the symptoms that they may be having?
Sometimes no symptoms at all.
None at all.
None at all. And we've seen that very recently in our practice.
We
Too
have.
often. Almost scary. Where patients have no symptoms whatsoever. They're actually exercising, doing every single thing that they normally do. And all 3 blood vessels are blocked severely.
Yeah.
And they don't know.
Yeah, so, having screening examinations
Screening.
done and
Yes.
testing and seeing your healthcare provider
Yes.
to see are you at risk, and if you are at risk, then doing the appropriate testing, and we'll talk a little bit about that in a
Yes.
minute. But going back to if you are having symptoms, what are some of those symptoms that you may have associated with having coronary artery disease or blocked arteries to the muscle of the heart?
So things as simple as decreasing your exercise tolerance, I tell people to look out for that. That could be an early sign where you used to be able to walk up these stairs, run with these stairs, and you can't because by the time you get up there, you're short of breath or you're having chest pain. And we know chest pain is one of the major signs of you having coronary disease or at risk for having a heart attack. And that pain can be as minimal as having a sticking or as severe as having crushing type chest pain where, it's unbearable to the center of your chest. There's also shortness of breath as well, faint because the coronary blood vessels are so severely blocked that you're not getting enough blood flow to the heart, that it may incite either an abnormal heart rhythm, or you can just have almost like, heart collapsed, if you want to say that as a dry term, not really medical. And those are usually weakness, excessive sweating, nausea, vomiting associated with the pain as well. So usually those are signs for having coronary artery disease.
And so, if you are experiencing any of those, you definitely want to see your healthcare provider and have an assessment done.
Yes.
But even prior to this, as we were talking about, there are persons that are at risk. Well,
Yes.
first of all, everybody can develop heart disease,
Yes.
right? But there are persons that may be at higher risk. And when we look at risk factors and we want to evaluate patients, what are some of the things that we can do from a testing point of view to be able to screen patients, as we've really recognized that screening is important and doing some proactive assessment of patients? What are some of those recommendations that you have for persons to get done?
So for screening, the first thing I say is look at the risk factors first. So if we're talking about hypertension, somebody who's over 50 years old, if you're a man, 60 for a woman. When it comes to age, also looking at, do you have a first degree relative? When I say first degree relative, mom, dad, sister, brother, any of them having a heart attack under the age of 40. So that's like early coronary artery disease or premature coronary artery disease. And if you do have any of those risk factors, you want to get checked early. The other things that you want to do for screening is, what is their cholesterol like? And we could get even very specific in this when it comes to this, especially now that the new lipid guidelines have been out this year, only a month ago, actually. And so not just looking at what your low density lipoproteins are, or even what your total cholesterol are, or what your triglycerides are, or what your high density lipoproteins are, which is your good cholesterol. And we say, the bad cholesterol is your low density lipoproteins, or LDL. We want to also do screening, which could be lifetime screening. And for lifetime screening, we actually do something called the lipoprotein little a. And this can tell you what your risk of heart disease is if it's elevated, okay?
So this is really getting down to the nuts and bolts of cholesterol,
Yes.
right? Taking it to the next level
To
is
the
how I
next
like to
level.
tell people.
Yes.
Like, there's a lipid panel, which is generally the cholesterol panel that you get when you do your annual physical, tells
Yes.
you the basics. But
The
this is really
basics.
getting and drilling down into those real numbers of what is going on with the cholesterol.
Yes,
Yeah.
absolutely.
And these tests are readily available.
readily
Right,
available.
and they can be done once you had your annual physical done. If your blood tests come back and you see that your LDL cholesterol is elevated, your physician may recommend doing these additional testings where we're looking at those fractions
Yes.
of the LDL, which you mentioned is the little LDL, and then there are other ones that we can measure as well, and other risk factors.
Yeah. So other risk factors, as we know, so for patients in terms of screening too, you also want to do your HbA1c for diabetes. And then, of course, the test that Dr. K is always sends the patients for me, and I'm like, which is, of course, your coronary calcium score.
Yes.
So I love the coronary calcium score. It's a good screening tool. I've identified a lot of asymptomatic
So
patients,
many
and we're
people.
talking about asymptomatic. We're talking about patients who have no symptoms whatsoever, and they're surprised by this. And then we prevent them from having a heart attack.
That's right.
And
yes.
that's what we want to do as
Exactly.
physicians. We want to prevent before it gets to the level of them going into hospital with damage as it relates to their heart. We're talking about heart failure. We're talking about having a massive heart attack, and then sometimes being a bit too late, going into hospital, heart muscle dies, etc.
Yeah.
So yeah.
So, folks, we're going to take a little break here at the top of the hour, and we'll be back shortly to continue our conversation with Dr. Morris, cardiologist and electrocardiophysiologist regarding the electrical activity of the heart in the second half of the show.
Sure.
Thank you so much for joining us on the Urologist Speaks.
Back to school is almost here. Guardian Media is helping you get ready with the Back to School Jam 21st from 11 to 3 at the Guardian Media Grounds on Carter Street, Oaks Field. Bring the family for an afternoon of fun, surprises, and all the school supplies your kids need for back to school, like books, pencils, school bags, and everything needed to start the school year off right. It's the Back to School Jamboree, Friday, August 21st from 11 to 3 at the Guardian Media Grounds. Guardian Media Group, informing, entertaining, and giving back to the people of the Bahamas.
For fast, reliable, and impactful printing services, look no further. Let Printmasters bring your masterpiece to life. We stand by our quality products that is second to none. Our affordable pricing and friendly, efficient staff makes Printmasters the ultimate choice for all your printing needs. We can deliver any type of printing services, from banners to booklets to business cards. You name it, we can print it.
Let Printmasters bring your masterpiece to life.
Located in the Nassau Guardian Building, telephone 302-2361.
Always on the go? Missed a show? You can now listen to Guardian Radio talk shows anytime, anywhere on Spotify and YouTube by searching Guardian Radio 96.9 FM or by entering the name of your favorite show. You can also listen by logging on to GuardianTalkRadio.com and clicking on the podcast tab. Guardian Radio, continuing to provide you with fresh news and smart talk anywhere, anytime, all day.
This is Guardian Radio, your station for up-to-the-minute news and intelligent, interactive, and engaging conversations. 96.9 FM.
Good evening and welcome back. This is Dr. Graham Cates. I'm here with Dr. Morris, cardiologist. And tonight we are talking about heart health. It's great to have you. Thank you to Dr. Pinto for allowing us to be on the show. We appreciate you. And we are so excited to be talking about the heart. So on the first part this evening, we were talking a little bit about blood pressure, cardiac risk associated with that. We also talked a little bit about the heart in terms of the blood vessels, the coronary arteries, and the risk factors, and how do we protect those. In this segment, I want to talk a little bit about the valves of the heart and talk a little bit about some of the common conditions that affect the valves of the heart and what predisposes people to have valvular heart disease. So let's first of all talk about what those valves are and why they're there, so people can have a general understanding of the function of them.
Yeah. So your valves, again, I'm going back with the house analogy. So we talked about the pipes. We didn't mention the electricity yet. We'll mention that a bit later. But the valves, I see them as the doorways. And these allow blood to flow in one direction in the heart. So they're very important. So they open to let blood into another structure, close when you want to keep the blood from flowing back into the heart, for example, or flowing back into the structure that they came from. So blood flows from, for example, on the right side, from the rest of the body into the heart to go through the right top. And then there's a valve there that separates the right top chamber from the upper floor from the lower floor, for example. And that allows blood to flow from the upper floor to the lower floor, from the lower floor to the lungs, right? So that's all on the right side. And then all of these, at these different points, have these doorways we call valves.
Right.
And any of these valves, so they're usually four. So there's two separating the upper and bottom floors of the heart, basically. And then there's also the ones that are for the major blood vessels. So we're talking about the major blood vessel going to the lungs and then the major blood vessel going to the rest of the body. So there are also valves there. When these valves become affected, and there's a long list of reasons why, and unfortunately, the most common in our population is because of the heart becoming enlarged. So these valves then become leaky, and the heart enlargement can be as a result of long-standing high blood pressure that has been kind of burned after it's gotten very thick. Then it starts to get big.
So that heart failure component we were talking about with
Yes.
the hypertension, and then the heart just expands
The
out.
heart just
And
expands
literally,
out.
anatomically, those valves
Those
can't
valves
touch
also
anymore,
no,
right?
they can't touch anymore or call coaptation, so they don't coapt anymore or come together, and they're wide apart because of the enlargement of the heart. So you get leaking of blood fluid. Directly affecting the heart valves itself, though, something that we used to see back in the day, which is rheumatic fever affecting the heart valves, so causing rheumatic heart disease. Again, it can either cause backflow of blood or leaking, or the blood vessels we see actually come closer together where there is almost like an obstruction of blood from going from one area to the next.
Right.
Yeah. And we don't see rheumatic heart disease as much as anymore because of the use of antibiotics. But we still see it a lot in our neighboring countries, neighboring Caribbean countries.
Yeah, when I was in Trinidad, which
Yeah.
is where I did my medical training, we had quite a number of patients that would come in associated with having rheumatic heart disease because
Yes.
of the not readily available or access to the antibiotics,
Yes.
which is commonly used to treat these bacteria that causes this particular valve of the heart to become closed.
Yeah. But also, we can be at risk if we do have things like dental abscesses. Dental abscess, so you need to also, again, the heart is not isolated on its own. Sometimes it's just general health,
Sure.
including dental health. So some patients, if you developed a cavity, it stays there for a long time, you get an abscess, some of the bacteria in that abscess can actually get into the bloodstream, and then that can also go to your heart valves as well. And that can affect your heart valves in that you actually cause almost like an abscess or what we call a vegetation on the heart valve. And these affect how the heart valves come together. So there's leaking again, or even getting closure depending on the severity. So that's mostly heart valves in a nutshell, I believe.
And so, what are the common groups of people that we see? You mentioned about the closing of the valve, and I guess one of the groups of people that I'm thinking about is the elderly.
Yeah.
As people get older, we
Yes.
know that they can develop something which is called aortic stenosis,
Yes.
which is not an uncommon condition.
No,
Actually, my
very
dad
common.
developed aortic stenosis,
wow.
and fortunately was able to have a valve replacement
Replacement.
done, which was extremely successful.
Yes.
And so when we look at that particular condition called aortic valve stenosis,
Yes.
it generally happens as people get older. How do these people commonly present, and what types of symptoms do they have?
So usually, as you said, in the older population, most times it's related to, as we age, we get calcium deposition in the heart, even valves, even on the heart, even in the coronary arteries as well. So elderly people are at risk for getting, as you said, aortic valve disease or aortic stenosis. And most of them present with shortness of breath, fainting spells. They can have swelling in the legs, fluid build up in the body, almost presenting like heart failure. So a lot of people don't No, they may have
Yeah.
it.
I mean, the only thing that my dad had was shortness of breath.
Yes.
And he thought that he was actually having sinus because he had
Right.
had a history as a young man of having sinus congestion.
Right.
And was taking antihistamines every
Yes,
day. And it
yes.
wasn't until months later
Right.
that he actually told me. And
Right.
after I examined him, I was
Then
like,
you heard him murmur.
wow. You know? And so something so simple, but yet so
Yes.
important to be
So
able to
important.
identify so that we
Yes.
know that you can do something about it. And there are
Yes.
procedures that are readily available
Yes.
for helping to correct abnormalities
Yeah.
associated with the heart, and even testing that's available. One of the common tests that's done is the echo,
Yes.
which is
Non-invasive,
pregnancy, right?
yeah.
Totally non-invasive.
Yes.
We just have a look at the heart. We can
Yes.
see the structure of the heart. We can see
Exactly.
the valves,
Yes.
the blood flow, the
Yes.
volumes of blood inside of the
Yes,
heart. It's
exactly.
amazing the
Yep.
amount of information that we can get associated with just doing a simple echo.
Yes.
And available in the clinics and in the community centers, certainly at Family Medicine Center and
Yep.
a lot of the other private healthcare facilities. So we've spoken about the valves. Let's talk a little bit now about the sort of electrical activity in the heart and what's normal, and then what are some of the common abnormal things that we see in clinical practice.
Yeah. So the beauty of the heart, again, if you were to take it and put it outside the body, it will still beat and still beat and still beat.
Crazy, eh? I mean, how
Just
can you believe there's not a God? Come on. Wow.
Yes, yes. And that's because of what we call automaticity, or your pacing cells inside the heart. You know, you can't identify them by looking, but it's very microscopic, and it's the way the heart just says, you know, I'm going to beat at this particular time. And the way the heart beats is it goes from those pacing cells to go to another set of pacing cells, then to tell the rest of the muscle to beat. And that average is, well, we call that normal sinus rhythm, where the heart beats in that rhythm, where you start in the right top chamber of the heart. It then goes to the middle and then to the rest of all the heart as well. And that is called normal sinus rhythm. Okay, so that's the rhythm that is normal.
That's what you
And
want to have.
That's what you want to
Definitely
have.
want to have a normal sinus rhythm.
So when you hear somebody say that, you know that's the normal rhythm of the heart. This excites me because this is my area of specialty. I'm a heart rhythm doctor. So the other piece to it is that it also would then dictate what your heart rate is. So generally, as I said earlier, your heart rate is generally between 60 beats per minute to 100 beats per minute, and then can go up depending on your aerobic activities. Now, if that goes higher for some reason and you're sitting doing nothing, that may be an abnormal, not just an abnormal heart rate where you're tachycardic, where your beats are greater than 100, but you can also have an abnormal heart rhythm as well. So no longer where it starts in the right top chamber of the heart and then goes to the rest of the body. It may start in another part of the right top chamber, or even the left top chamber of the heart, which is very, very common. And the most common rhythm problem we get, which originates from the left top chamber of the heart, is known as atrial fibrillation. So that is just a fancy term to say that the left top chamber of the heart having triggers coming from the pulmonary veins, and these in embryologic life, they all were together. And then eventually they kind of separated. And the pulmonary veins is where blood comes from the right side of the heart into the left side to get oxygen. And that left top chamber goes fast. It almost what we call fibrillates
Right.
to the point where it causes your left top chamber to go at a crazy number. So 250 beats per minute, up to about sometimes even 400 beats per minute. And luckily, again, God allowed you to have this very protective mechanism called the AV node, and that protects you from your bottom chamber, again, going at 250. So only half of the signals get down with
Right.
atrial fibrillation, or even sometimes a little more than half, where then your heart rate is about 160 sometimes with this abnormal heart rhythm. And that's very common. So I often tell my patients, if you are over 65 or if you have risk factors, again, like diabetes, hypertension, heart failure, those increase your risk for getting atrial fibrillation. And atrial fibrillation is very common in our elderly population as well, where sometimes, well, the statistics show worldwide that 1 in every 3 80-year-old will have atrial fibrillation. And it's also common in younger populations as well.
Right.
But mostly seen as a heart rhythm problem of an aging population.
And so how do you identify that? I mean, clinically, but also testing-wise.
Yeah. So clinically, by the way, some people are actually asymptomatic
Right.
for atrial fibrillation, so they have no symptoms whatsoever. There are other people who are extremely bothered by AFib, so they get short of breath, they have palpitations, which is the heart beating very fast, almost out of their chest. But a simple test, the electrocardiogram, tells us whether you're in atrial fibrillation or not. And that is just the stickies that we put on. And then the little blips on the paper tracing.
Yeah, it makes us look really smart when we look at those pieces of paper. I'm telling you, I hold them up and I'm like, wow. But it's pretty simple, but you
Yeah.
got to know what you're looking at, right?
Yes, you do.
exactly.
Yeah.
So, yeah, the ECG is one of those tools and, again, readily available.
Readily available.
I mean, most
everywhere.
clinics have
Yep.
an ECG. You can get an
Yep.
ECG done. And have a look at it, and if it's abnormal, then of course your arena is to sort of help to manage this. So,
Yes.
what do you do for patients with atrial fibrillation, and how do you treat them?
So I would say atrial fibrillation is, to me, one of the most complex things to treat, to be honest with you. For me, I often say for AFib, it depends on your presentation. So if you are what we call stable versus unstable. So if you come into the office, you're in AFib, your blood pressure is normal, that is something that we could potentially treat on the outside.
Okay.
If your blood pressures are low, you're feeling unwell, you need to probably go into hospital. And if you're going pretty fast, sometimes depending, it kind of doesn't matter if you might be, your blood pressures may be normal or slow. Sometimes that may still be something where you might need to treat in hospital. And then, of course, I look at all your risk factors for it. So if you're unstable, you have to go to hospital, and we need to get you back into your normal rhythm as quickly as possible. Okay? And for people who are stable, most times I say I always want to give patients the opportunity to get back into their normal rhythm.
Okay.
Right? At least once, give them the opportunity. Sometimes I do it twice, all depending on their symptoms too. If you have lots of symptoms, you're bothered by it, I often say my first preference is to get you back into your normal rhythm.
Okay.
And then, of course, one of the things I also look at is, how is this affecting your heart muscle? Okay? Is it causing your heart muscle to be weakened, or is your heart muscle normally functioning? So we're talking about the house again, the
Right.
structure. If your heart function is lower because of atrial fibrillation, I often say the best thing to do is to get back into your normal function, normal heart rhythm.
Which
And-
is that sinus
which is
rhythm.
the normal sinus rhythm, yes. And then we can deal with your structure as time goes on. And then the funny thing is that some people, if you get them back into their normal rhythm, their heart structure gets normal again. So it may be atrial fibrillation affecting their heart muscle structure or how it functions. And again, of course, that is the test we talked about not too long ago, which is the echocardiogram.
Right.
Very simple to do. And then we also want to see what may be causing it. So this could be genetics. This could be related to the risk factors we just talked about. Or it could also be related to a valve issue. One of the most common valves associated with atrial fibrillation is mitral valve disease. So we're talking about somebody who may have a leaky valve there, or even a tight valve. And for those people, we kind of treat a little differently, and I'll talk about this. So one of the other things people talk about atrial fibrillation is that it's not a dangerous heart rhythm problem. People get afraid, frightened by it because people's heart rates go fast and you're
Sure.
scary. but it's not dangerous. So one of the things we worry about, though, is the formation of clots in the left top chamber of the heart, and especially a very rudimentary area we call the atrial appendage. The clots can hide in that area, and then those clots can break off and cause a stroke. So that's where atrial fibrillation can be scary. But I must say that not everybody is created equally with atrial fibrillation in terms of their risk for a stroke. So meaning that because you have AFib doesn't necessarily mean that your risk of having a stroke is high. We have to evaluate that. We use scoring systems to determine. And after we do the scoring systems and you're young and your scoring system is 0, your risk is extremely low to almost nil of having a stroke, versus somebody who has lots of risk factors and then their risk of having a stroke is high. If your risk is high, I'll park for a scoring system called the CHAS-2 VAS, which is just a fancy term for saying that looking at all the risk factors, putting them together and seeing what your risk of atrial fibrillation is. And we say that depending on your score, then you have to go on blood thinners to minimize your risk for having a stroke. Yeah. And that's pretty much kind of AFib in a little bit of a nutshell. And then, of course, we want to get that heart rate lower. We don't like 160. So we put them on medications to slow the heart rate down. There's also the option of, besides getting the heart back into its normal rhythm through like electrical shocking, sounds scary too, but very simple procedure too. There's also the option of getting your heart rhythm back into its normal rhythm through medications as well.
Amazing. So when we talk about the electrical activity of the heart, and I know this is your passion, and one of the reasons I want to lean into this a little bit more is there are other things which can be done.
Yes.
In terms of studying the electrical activity of the heart, and also permanently correcting.
Depending, not for AFib.
No, not for AFib, but other conditions of the heart, right?
Absolutely.
And so let's talk a little bit about that in terms of this, the advances that are happening in us managing the electrical activity of the heart. So, what is that? What is this electrical study that can be done? And what are some of the things that can be managed by it?
Sure. So we call this test an electrophysiology study. And then going a step further, something called ablation, where we use it to either treat or even cure, as you stated just now. So what that fancy term is that we put small tubes in the heart and we stimulate the heart and we kind of see where this fast or abnormal heart rhythm is coming from. And then once we identify the area where it's coming from, then we can take a small catheter, again, tube, to use thermal energy to burn areas. There's also the option of doing freezing energy. That's called cryotherapy. And then new and advanced therapy, which has been happening over the past, I want to say 5 years, is this new technology called pulse field ablation. Again, using very high voltage energy to get rid of these abnormal electrical things that can happen, causing these abnormal rhythm problems.
And I mean, this is really revolutionizing the way a lot of the historical ways in which we manage.
So not just using medication.
Exactly. So these patients now become literally medication free.
Yes, medication free.
Completely
Absolutely.
medication free, because we're correcting this abnormal electrical conduit, literally, that's been created.
A channel. Yes.
Yeah, the channel, and we're blocking that.
Yes.
Which then takes these people literally back
Off
to a normal.
Yes, back to normal life.
Normal sinus rhythm.
Yes.
And that's where we want you to be.
Yes, absolutely. Unfortunately for atrial fibrillation, even though we have ablations available and even the new technology, unfortunately, the effectiveness of it is not, 100%. We say most times to get somebody free of atrial fibrillation with an ablation therapy or ablation strategy, the success is about 50 to 75% for this first ablation, but for sometimes we can do up to 5 ablations for some people with atrial fibrillation,
Wow.
just because they're bothered by it most
Understood.
times,
Okay.
right? But for other conditions, such as our supraventricular tachycardias, these can have like a 95 to 99% cure rate.
Wow. Incredible.
Using therapies. And there are some people who get so bothered by them. And we take them to the lab, we put these catheters in or little tubes in. We get rid of that extra conduit or channel, as you alluded to, that tends to take over the normal sinus rhythm occasionally. And then people are free of it most times,
Incredible.
off medications.
Absolutely
Yeah.
amazing.
Yeah.
So I'm in from one of the persons listening who's chatting with me online, and they were saying what we were talking about a little bit earlier in the show was coronary artery disease. But their question is, what is a heart attack? Why do
Okay.
people have a heart attack? We having a heart attack, and also what can we do in patients that are having a heart attack?
Right. So what a heart attack is, remember we were talking about the coronary disease, which are the little pipes or conduits that take blood to the heart. One of these can become blocked with plaque formation. Sometimes the plaques don't completely occlude or block that vessel. But what happens is one of the plaques may become exposed. After it becomes exposed, the body sees it as something it needs to treat. Unfortunately, what happens is blood goes to that area to form a clot, and that clot completely can block off the blood vessel and then cause decreased blood flow to the heart. When that occurs, that's when you get a heart attack most times. Sometimes some people do get that blockage off, but that may occur just with having the plaques blocking the blood vessel. And then sometimes that blood vessel may become completely blocked and they not know. But most times when that occurs in an acute setting where the blockage is complete, then you start, because there's no blood flow to the heart muscle, you start to get pain.
Okay.
That pain occurs because of increased oxidative stress, almost like if you were running and you start to get a cramp. So it's almost like there's no oxygen and nutrients going to the muscle appropriately. And then you get severe pain, there's a blockage, and that's, where you get your heart attack. So it's severe chest pain, as we talked about earlier. Some people become short of breath. Some people actually faint, because sometimes with some of these heart attacks, you get abnormal heart rhythms that can cause you to faint. Fainting can also be because a major blood vessel was blocked to cause low blood pressures as well. So for somebody like this, if you are developing chest pain, or if you have a relative that may be developing chest pain or has chest pain, the first thing you should do is absolutely call 911 and get that person via ambulance to the hospital. And the reason for that is because we always say time is muscle. So the quicker you get there, the quicker we can save that heart muscle. And we can either give you medications to break off that clot, which we do for everybody, but also we can do special procedures called angiograms, and we can use balloons, wires, and small mesh devices called stents to open back up that blockage in the blood vessel.
Like a plumbing job.
A plumber. A plumbing job. Absolutely. It is a plumbing job. So we're talking about the pipes, and yes.
Get those pipes open again, get that
My
blood
colleagues who
flowing.
are the heart plumbers, they know what I'm talking about.
Yes,
and
yes.
yeah, they get it all opened up.
Amazing. So really early recognition is
Yes.
key. Get to an emergency department where
Yes.
you can be seen, assessed, and then a diagnosis can be made. And
Absolutely.
you can get the appropriate treatment associated with
Yes.
if you are having a heart attack.
Yes.
Yeah.
Yeah.
And once the treatment is given, then
Yes.
there are follow-up in terms of medications
Absolutely.
and medical management and risk factor reduction,
Reduction.
all of the things that
Yes.
we spoke about already, just in terms of minimizing the likelihood of any recurrence.
Exactly. People often don't realize that once you've had one, the likelihood of you having another is still there,
Right.
right? Because most times it's one blood vessel that's blocked, but it doesn't mean that the other blood vessels can't be blocked as well.
Sure, absolutely. So we're going to get ready to wrap up here in a few minutes. So let's just sort of conclude by talking a little bit about just prevention, heart disease prevention. What are some of the key messages that we want people to take away from tonight in terms of just looking after yourself and your well-being and your heart and blood vessel well-being?
So first of all, have a healthy lifestyle, whether that be you getting out there, walking, running, doing something that you absolutely love to do, getting your heart rate up, dieting. We actually didn't go into that at all, but diet is very important for healthy. So, one that is low in cholesterol. You have moderation in terms of your fats, so mostly healthy fats. And you also want to minimize carbohydrates as well. People don't understand that that plays a vital role in the development of diabetes.
That's all them starches.
Yes, that would be love. So we have to minimize those. That should be a quarter of your plate, not the full plate, right? Using more vegetables, using nuts, protein, these things are important for a good diet. And then, of course, seeing your physician, knowing your numbers, that's absolutely important. Knowing what your blood pressure
Don't
is.
be afraid of us.
Yeah, don't be afraid of us.
Love
We
you.
don't.
We love you. We want to look after you.
Yes, we want to see you and your family healthy. They want to see you all around for a long time. So yes, you need to know your numbers, see your physician. When you talk about numbers, know what your blood pressure reading should be, know what your blood sugar should be, know what your cholesterol, the good cholesterol should be, what the bad cholesterol shouldn't be. So in general, just kind of know your numbers. And then more importantly, you want to live life. Don't feel restrictive in any way. Just do the things that you love and, you'll probably have a healthy heart. Because we didn't even talk about what the role of stress could be as well.
Well, there's a whole bunch of things. I just
yes.
have to have you back again so we can talk about these things the
Absolutely.
next time. There's a
Absolutely.
lot that we have to cover.
We do.
So we really want to thank you for taking the time to join us. Again, thank you, Dr. Pinto, for having us here tonight. Urologist Speaks. We appreciate the opportunity of sharing with you. We look forward to seeing you next time. On behalf of Dr. Morris, cardiologist, and myself, Dr. Graham Cates, thank you so much. God bless. Have a wonderful evening.
Have a wonderful evening.
Help from the urologist.